Yeah.
Hi, good evening, everybody.
Good evening, sir.
Good evening, good evening. Hi, Arshul. Hi, Vishal.
Hi, sir.
Hi, Kakadia Saab. Good evening, Manish. Good. Lots of people.
Hi, sir. Good evening.
Hi,
Hi, Suven.
hi
Good evening,
Ajay.
everyone.
Hi,
Hi,
Viru.
Suven.
Hello.
Hi.
Sai, can we start?
Doctor, we are live now.
Okay.
Okay.
So, a very warm welcome and good evening to all the speakers, panelists, and delegates who have logged in for today's webinar, Imagine 2.0. As you all might be knowing, JOS, Jaipur Ophthalmological Society, is one of the
share your presentation now.
most vibrant and active ophthalmology societies in the country, conducting regular academic activities and live surgeries throughout the year. Many of its members are academicians of national and international repute. Not to mention the ever increasing participation in the AIOS leadership. Unfortunately, during the present pandemic, all the physical activities have been stalled, and we don't know for how long. Nevertheless, academics should go on, and virtual meetings are the best way around at present. So, in continuation of the webinars JS has been conducting, we present Imagine 2.0, another add-on to our Imagine series, which basically is based on showcasing what's new and exciting in the field of ophthalmology. It may be related to therapeutics, diagnostics, or any part of our specialty. The title includes not just new innovations, but also indigenous modifications of the commercial products which were already present in the market, and they were modified by our colleagues to suit our need. So this is the second episode of the Imagine series conducted by JOS. I feel privileged to welcome our esteemed speakers, Dr. Ajay Arora, a prolific surgeon, VR surgeon, a great innovator, and a fitness freak from New Delhi. Dr. Manish Bapai, my good friend, a great surgeon with many innovations to his name from Nashik. Dr. Suven Bhattacharya needs no introduction. We'll hear more about his innovation in his keynote address. And because now he's an international figure with the, if I'm not wrong, the recent FDA registration of his device. And Dr. Jagdeep Kakadia from Bhavnagar. He has a long list of low-cost innovations. He has a great scientific mind. And I personally recommend this talk to all of you, a not to be missed talk. I now welcome our President, Dr. Virendra Agarwal, sir, to start over the proceedings of today's evening. Dr. Virendra, sir, you are muted.
Yes, can you? Yeah. Yeah. Thank you, Vishal. And it's a very good idea of keeping the innovations known to every member of JOS and across India if possible. And our own people who are doing a lot of innovations for help and of a low cost and of a daily need. I think it is a good session for all of us to hear and learn new things about the new innovations from the great speakers. And I welcome all the good speakers from the India, and they are sparing their time for our Jaipur Ophthalmic Society. Now I hand over it to, and our panels are our own eminent doctors who are from the Rajasthan itself, and I welcome them all, and I am thankful for sparing time with them this session to start in time. Nitesh and Amit, please take over.
Uh, Good evening, everyone. On behalf of JOS, I would like to welcome all the speakers, panelists, and members who joined the meeting. To start with, first, I'm giving a brief introduction of Dr. Ajay Arora, sir. He is a reputed vitreoretinal surgeon and presently the director of vitreoretina and uvea services of Vision Plus Eye Center, Noida. He did his retina fellowship from Retina Foundation, Ahmedabad, followed by Vitreous Uvea and Intraocular Inflammation Fellowship at University of California, San Diego. He also worked as assistant professor of ophthalmology at CMC Vellore and at Institute of Ophthalmology, Aligarh. He trained many residents and he was the head of veterinary services at Dr. Shroff Charity Hospital also. And he won many awards. So it's a long list, and due to paucity of time, I would like to invite him for his talk. Sir, please, sir, Dr. Ajay Arora, sir. Hello.
Yeah, thanks a lot. Thank you
Yes, sir.
so much. Let me share my Can you see my screen?
Yes, sir.
Is it visible? Yeah. Okay.
Yes, sir.
Yeah.
So at the outset, I must thank Vishal and the Jaipur Ophthalmic Society. You know, I am very close to Jaipur in multiple ways. Been to Jaipur as faculty and personally on multiple occasions since many years, because I have very close relatives who are based in Jaipur, and Jaipur is like next home to me. It's interesting that my when I finished my MBBS from JIPMER, my home address actually on my certificate for my internship was given as Jaipur. It was in C scheme. So it's a long history, and I'm honored by this invitation by the Jaipur Ophthalmic Society and Vishal. My talk is not actually innovative in the sense that it's not I'm not presenting any of my innovations at the point of time, but I'll be talking of optimizing anti-VEGF therapy in neovascular AMD. So this is just to recapitulate what AMD looks like. This is for the postgraduates. I think all of them know about it. And we know that there have been numerous developments over the period of years, from thermal laser, photodynamic therapy, and the game-changing thing happened in October 2005 by Phil Rosenfeld when he first injected Avastin, and after that is all history. And then it has been newer developments, newer imaging techniques, and now we look at optimizing our therapy in such a way that the patient is benefited maximally. We know that anti-VEGF therapy has reduced the incidence of neovascular AMD associated blindness, and therefore that is the way to go forwards. We have multimodal imaging techniques now available, which help us define the disease much better, like colored fundus photography, fluorescent angiography, fundus autofluorescence, ICG, and OCT angiography. There have been numerous studies right from 2006, like Harbor, Marina. Then there was a BIAS study for quarterly injections, CAT study where for the first 24 months, monthly injections were given, and then the Harbor study and the Treat and Extend, and numerous other studies have come up. Now, what is meant by optimization? Optimization means maximal benefit with minimal dosage. That's briefly is a translation of optimization of therapy. The maximal benefit to control the disease can be reduction or absence of exudation in neovascular AMD, reduce associated fibrosis, maintain or improve visual acuity, reduce or produce an absence of recurrence. Minimal dosage is reduction in number of injections over time. It could be reduced number of visits without compromising control of disease, and reduce patient and attendant travel, which would save on patients as well as attendants time and money for the family, and of course the investigations. So therefore, to optimize treatment, it's important to treat early, which means you must diagnose the patient early. You must treat the patient sufficiently, and this sufficient treatment should be sustained so that you can cause abeyance of the disease, or the disease sort of becomes quiescent and remains quiescent for the subsequent period of follow-up. Now, the fundamental principles of ideal treatment, as I enunciated earlier, are you have to maximize patients' benefit. You have to decide when to treat next, and when to stop the treatment. And you should know how to monitor the treatment. Now, there are various regimes. I will not go into the details because I thought I'll show you cases rather than show you studies. So there are treatments which can be personalized to the patient. There are regimes which are given on a bi-monthly basis, quarterly, PRN, treat and extend, wait and extend, observe and plan, and we'll briefly look at what exactly they mean. So whenever a patient has to be given any treatment, the patient has to be assessed by all these things: visual acuity, multimodal imaging, and OCT, angiography, ICG. So therefore, every time the patient comes back, you need to do this investigation, which means there's a significant amount of workup which a patient requires. The treatment protocol can be monthly, and invariably for the loading dosage all over the world, we require to give 3 monthly injections. Once you have done the monthly injections and the fluid has disappeared, then the patient can be followed on a PRN basis, or alternatively, you can observe the patient monthly till the fluid appears, and then you inject, and that is what PRN means. Then you have observe and plan. In observe and plan, you have a patient where there's a baseline visit. You give the patient loading dose, which may be 3 or more, till there is no fluid. Once the patient has become dry, please look at this. Either you can continue injecting on a monthly basis, or you can increase by about 2 weekly. So initially you go for 3 months, you inject 1.5. That means you increase it by about 2 weeks. Then you make it 2 months. That means you increase by 4 weeks. Then you increase it by about 6 weeks. You again give 2 injections, and then maximally you can increase it by 3 months. So this is a little different from treat and extend. So initially 3 loading doses, then 1.5 months 3 injections, then every 2 months 3 injections, then 2.5 months 2 injections, and maximally 3 months 2 injections. And then you decide if the disease has become quiescent, and then you could decide whether you want to defer the treatment, stop the treatment, or follow on subsequently at every 3 monthly in the subsequent period of time till the disease has got stabilized. Now, what is treat and extend? In treat and extend, you inject till the fluid disappears, it becomes dry, and then you start extending the treatment, which could happen by 2 weeks or 4 weeks. And then you decide at what interval the fluid appears once again for that particular patient. So you go back about 2 weeks, and then that becomes the interval which is appropriate for that particular patient. So this is the treat and extend regime. This is the most common regime which is being followed now worldwide, and I think increasing number of people within our country also are. Most of us actually follow PRN, but most of us are now switching over in our patients who are intelligent and are able to follow up and are able to understand the significance of treat and extend, and we are switching over to treat and extend in those patients. So this shows the various studies which give evidence of treat and extend regime. The next thing, which is very topical and popular now, is to look at the fluid, because I think all the studies basically are looking at fluid within the retina, and we are treating the fluid because fluid means activity. So this is a retina which is dry, it has no fluid. You can either have sub-RP fluid, a subretinal fluid, or an intraretinal fluid. So this is just an example of various types of fluids in various conditions. The sub-RP fluid occurs initially when there is a choroidal neovascular membrane below the retinal pigment epithelium, which extends into the subretinal space, becoming subretinal fluid, and subsequently into the intraretinal fluid. Unless and until the scene means originating in the subretinal space, then you can have fluid starting in the subretinal space. Now, CATS study showed that initially when the patients were enrolled into the study, 82% of the study patients had fluid. And interestingly, when these patients were followed up for 2 years, almost 24 to 30% of them still had fluid, despite the fact that they were given monthly injections. Now, Amongst the various types of fluid, at the onset of CAT study, 82% had SRF, 75% had intraretinal fluid, and 49% have sub-RP fluid. Now, this is various studies where all of them, fluid is the key retreatment criteria. And all these landmark studies have looked at fluid as the retreatment criteria for giving anti-VEGF. Now, the current society guidelines also indicates whether it is EURETINA or the Royal College of Ophthalmologists or the American Academy, the guidelines recommend that treatment decisions are based around the presence of fluid, whether it is intraretinal or it is subretinal. So therefore, all fluid is pathological, and there's a lot of debate these days about good fluid and bad fluid. But please understand, any fluid is pathological. It is just that whether your agent or the drug which you're using is able to get rid of the fluid from the retina, and how much is the tolerable fluid, which I will just enunciate from the fluid study, which would show that up to 200 microns subretinal fluid can be accepted. Now, clinical relevance of the fluid is it helps us in diagnosis. It leads to the initial treatment. We're able to see the disease activity, all the visual outcomes, and are able to decide the treatment interval, again, based upon the fluid. Now, this is a very important study which was conducted in Australia. Basically, 349 patients. We had two arms, an intensive arm and a relaxed arm. The intensive arm, basically, they gave ranibizumab on a monthly basis until there was a complete resolution of SRF and intraretinal fluid. And in the relaxed arm, they waited for the resolution of intraretinal fluid, and subretinal fluid less than 200 microns was tolerated. Now, essentially, this study was conducted between October 2013 to 2015, and these were the criteria for disease activity, basically indicating loss of best corrected visual acuity of about 5 letters, neoretinal hemorrhage, presence of fluid, particularly the intraretinal fluid, and in the relaxed arm, as I said, less than 200 microns was tolerated as the acceptable fluid. Now, when we look at the visual outcomes, it appears that visual acuity improved in both the groups despite there being inadequate resolution of subretinal fluid in the relaxed arm. This again shows the intensive group and the relaxed group, which shows that tolerance of some subretinal fluid did not adversely affect the visual outcome. So the fluid study said that if you have a patient where on a treat and extend protocol, subretinal fluid appears which is less than 200 microns and it is not resolving despite monthly treatment, it is possible to extend the interval of treatment regardless of the presence of subretinal fluid. But what is important to realize that most of the studies have looked at two years and not beyond that. We do not know what this persistent subretinal fluid, which is there, which is less than 200 microns, what damage it will cause to the photoreceptors over a period of time. And that is something which we would come to know on a long-term follow-up. Now, let me share a few cases. Now, this is a patient who I've been following for last almost 4 years. He came to us in the right eye, underwent cataract surgery, received multiple injections of Lucentis and Eccentric subsequently, till about in 2018, when he was not responding, and that is when his picture was this, and we thought that it is actually, we looked at OCT angiography and found that possibly this was an PCV. Therefore, he was started on Eylea, and he received Eylea in the right eye. He has received Eylea now for over a period of last 2.5 years. and he responded dramatically well to aflibercept. And this is his picture. Visual acuity improved from 624 to 612. There's a disappearance of intraretinal fluid. There is hyperreflective material present in the subretinal space, but there is no intraretinal fluid. There is no persistent subretinal fluid. This is his OCTA at the ORCC level over the period of time, and he has done well. And now he is on a treatment every 4 months. He is getting an Eylea injection and he's stable. What was interesting, so this is over a period of time how he has responded. This is OCTA over a period of time. And interestingly, in the left eye, when we were treating him for the right eye, he had some persistent fluid, but he refused any treatment. This is December 2019, when he underwent cataract surgery, and instead of Eylea, though we had suggested him Eylea, he said, no, he'll have an Avastin before the cataract surgery. I normally give an anti-VEGF injections if I suspect a choroidal neovascular membrane in the eye to be operated. So in February, he received his first Eylea, and then he did not turn up during the pandemic, and has recently had a second injection. So just to show you that some amount of fluid with the choroidal neovascular membrane of the type of PCV can remain without an increase in the fluid over a long period of time. And it is important to respect patients' desires and patients' opinion, but follow them up on a regular basis. Now, this is an interesting patient who is 71 years old female, underwent a multifocal IOL elsewhere, came to me with her best corrected visual acuity was 6/9. She had undergone mastectomy with a radiotherapy 20 years back, and she had a large subretinal membrane, which was extrafoveal in the upper temporal and lower temporal area. You can see here this SHREM present, which is diffuse, which is looks like the exudate in the sub-RP area. There is some fluid in the subretinal space. So he had multiple PEDs with sub-RP and subretinal SHREM, diffuse and fuzzy. And she had a PS here, peripheral exudative hemorrhagic chorioretinopathy. So this patient received initially Eccentrix. This was on the 11th of March. Vision was 6/12. Subsequently, we gave her injections, the second one at 3.4 weeks, third one again at 3.4 weeks. And subsequently, when she was not responding, actually her vision had dropped to 6/24. She was switched over to Eylea. She was actually suggested Eylea at the beginning, but she had refused. And initially, we gave her the injections at 4 weeks, 4.2 weeks, 6.3 weeks. Her visual acuity improved from 6/24 to 6/12, and now has stabilized, and she's getting injections every 6.3 weeks. So please look here. This is her OCT on 25th of April. This is the OCTA, which is at ORCC level. You can see the membrane which is present here. And this is on 11th March, 25th April, and 30th November. And this is the 6th injection of Eylea when the PED disappeared. And after the 4th injections, the patient's patience was, it was becoming difficult for her to be explained that she needs additional injections because her visual acuity was reasonably good. Interestingly, we followed the PSCR. This is on 25th April, an OCT which is taken here. You can see a large amount of subretinal fluid. Again, on 30th November, the OCT which has been taken through this membrane, and you can see the fluid has significantly reduced. I would definitely love the panel to let me know what do they think and how this patient needs to be followed up, especially for PSCR, because her visual acuity, as far as her membrane in the macula goes, she's doing pretty well. Her vision is almost 6/6 part. This is her montage at the ORCC level. So you can see her, she's doing this one on the angioplex, and you can see again the thing at ORCC, the B scan. The membrane has virtually disappeared. There's no intraretinal or subretinal fluid present. So this is the third case, which is a patient who is a 68 years old female, blurred vision in the left eye, came to me in August 2016. Right eye visual acuity was 6/6, left eye was 6/12. So initially, she received Lucentis at 4 weeks. Then the interval was increased to 7 weeks, 6.4 weeks, 8 weeks. She's actually mother of a cardiologist. And then in between, she became a little relaxed, did not come on time, kept on receiving Lucentis, and at a point where her visual acuity dropped to 6/18. Now, at that point, we decided that we will give Eylea. And what I want to show you here is we gradually titrated her treatment in such a way that we could reach the appropriate period of interval at which she should be injected. So initially, she was doing well with the visual acuity with interval of 11.3 on 8th of December 2018, did well at 7.4 weeks, 9.2 weeks. Subsequently, she noticed on her own on 11th May 2019, I'll show you the pictures, that her visual acuity went down. So it is important that we must give our patient home Amslers and tell them to look for any drop in visual acuity. So even if you have decided to inject the patient at a particular interval, if the visual acuity falls down for any particular reason, they should come back well in time so that you are able to inject. So she came back. This is on 17th of October. This is the slab taken at the level of choroid. Please note here that the vessels which are deeper down have started maturing. And I think this is important. I will definitely like to have comments of the panel. The vessels look pruned. There are fewer branching points and they are dilated. There is hardly any branching vesicular network. And when we look at the same picture at the ORCC, you find a large branching vesicular network, which you can get on the UNFAS image. But at this stage, there was no SRF, there was no intraretinal fluid, and there was no SHREM. There was a branching vesicular network present. So this patient was being followed at an interval of about 11 weeks. She then came back. We could find at a subsequent follow-up that there was a little activity. And since this activity was decided, we decided to inject this patient. This is, again, she came back to us in April 2019. There is greater amount of subretinal hyperreflective material with fluid present. And you can see the same thing on the UNFAS image. And this is a follow-up over a period of time. You can see it on 2nd February 2019, April 2019, June 2019. With over a period of time, her fluid reduced and she is gradually become dry over a period of time. This is on October 2019. This is December 2019. So there was a gradual reduction of SHREM, gradual disappearance of all fluid, which means intraretinal fluid, subretinal fluid, sub-RP fluid, gradual improvement of the structural and angioplex ORCC, and improvement of visual acuity. And now she's hovering around 6/6 parts. Her this is her picture, was her picture on 30th of January when she started having some more fluid. So now we look at her Eylea story, which was subsequently, her last follow-up has been on 28th of November 2020, where We have extended her injection period of 12.1 weeks with a stabilization of vision of 6.9. So this is how she looked like. So this is November 2020. There is no intraretinal fluid, no subretinal fluid. She's looking very stable with a 12-week of follow-up. So the take-home message from this case is that initial injection in any of her cases could be Avastin and eccentric. Try to identify the type of CNVM which you have, whether it's PCV or an AMD, understand the concept of the loading dose and understand the posology of the drug, and you can extend the period accordingly so that you can optimize the treatment. Each case may require a specified interval of injection, and this may be quite specific. I'll just finish. So you must trust the patient's intellect. Like this patient came back when her visual acuity dropped, and periodic imaging is important. So the take-home message, as I said, loading dose, regular monitoring, multimodal imaging, extension by every 2 weeks, and then adjust. Trust your patient, teach the patient about the utility of Amsler and home, and observing, her visual acuity at home, and then you can decide which treatment to give. And now when we have an Eylea for You program, the costing is almost similar, both for aflibercept and eccentric. Thank you for your kind attention.
Thank you, Vijay sir, for the great insight into the role of aflibercept. And we'll have just two short comments, quick comments from the panelists, Dr. R.K. Sharma sir and Dr. Abhishek, before we move to the next talk. Yeah.
Yeah, so, hi Vishal. I agree with most of what Dr. Ajay has said, and that's what we usually follow. Of course, we are limited in our following up of the treat and extend regimen by the patient's economic choices. But yes, I would again agree that Eylea has done a wonderful job, because the way it dries up the retina and the way we have this long-term effect and less number of injections are required, we are still able to stick quite well to the treat and extend. What we usually do is that instead of treat and extend, pure treat and extend, we make it a wait and extend. So we treat and extend till 3 months, and if it is dry beyond 3 months, we wait. Then we don't keep on injecting at every 3 months. So that's how we do it, and I think he showed the few cases, they do very well. With Eylea, they do very well.
Okay. Dr. Sharma sir?
Yeah, thank you, Dr. Vishal. And thanks to Ajay. Nice presentation, nice cases, and nice
I
documentation.
must say that Dr. Sharma has been, my teacher also way back in Retina Foundation. We call him RK Boss.
Thanks for the kind words. See, this case number 2 where you said the patient developed no PL.
No.
Maybe you have to look at the CRO point of view.
I never said he had no PL. No, there was no case with no PL, sir. I think maybe it's not
you
audible.
said PL.
No. Patient had, she had peripheral exudative hemorrhagic chorioretina. Her vision was 6/9, not no
Okay.
PL.
Yeah. So that case, if the vision was 6/9, I think you can continue till the fluid is there. But the point is, if the macula is not involved and it is far away from the macula, do you still need to continue? Or can you think of something else like brachy or something like that?
So,
Instead of, because this is a case of, carcinoma, you said.
No. This is not. We did PET scanning for the patient, and PET scan was negative. The peripheral exudative hemorrhagic chorioretinopathy actually has got a very nice course that it may spontaneously regress. What I wanted to know from people is, the panel is, what is their experience of giving injections versus doing a laser treatment for this patient once the fluid has become less, because sometimes laser can actually cause a massive hemorrhage which can trickle down to the macula. So that was my contention.
No. I would like to wait for the subretinal neovascular membrane to resolve before you do a laser, because this is not very far off from the macula, and treatment can be continued with the injections. We should continue.
Okay.
And I have 1 or 2 questions to you.
Yes.
till what time would you like to continue treatment, and when would you say, okay, stop, no treatment is required now, in case of AMD, neovascular AMD?
So like the first case which I showed you, sir, his right eye is on a follow-up of almost every 5 months now, and the left eye is on a follow-up of 6 months. So in this patient, it's a normally treat and extend by the Altair study and ARIS study. The maximal they have extended is about 4 months. But there have been cases which have been reported all over the world beyond Altair, which have the follow-up is up to 5 years, where they've said that patients at some point of time after about a third year have been temporarily stopped intervention. So I think then it almost becomes a PRN therapy. You follow the patient on a regular
basis. That's what I wanted to come to. After a certain period of time, you can switch on to PRN from treat and extend.
Correct. Yeah, especially in our country, once you know that the interval has extended almost to 4 months.
Okay.
Yeah.
So we can have the rest of the questions at the end of the session. We have a couple more for Dr. Ajay.
Yeah.
Actually, Dr. Suvain has to leave for a personal commitment at 8:45 or 9 o'clock. So we can have his talk before Dr. Manish, if Dr. Manish permits. Dr. Suvain, sir, are you there?
I'm ready. Yeah, I'm ready.
So can you upload your slides, please?
Yes, please. Sure, I'll do that.
Nitesh?
Yes.
Can you give a brief introduction of Dr. Suvain Bhattacharjee, sir?
Good evening, all the speakers and panelists. As we all know, am I audible, Vishal?
Yes, boss.
Yes.
As we all know, Dr. Suvain needs no introduction. He's an inventor and entrepreneur along with the efficient ophthalmologist. Currently, he's consultant at Nayan Eye Center, Kolkata, and he's the founder of Med Invent Devices Private Limited and invented the most popular Indian pupil expander device known as BHEX and having initial patent of this. He has received prestigious AIUS Dr. P. Siva Reddy International Award, Colonel Rangachari Award for Best Paper, CS Reshmi Gold Medal for Video, and many more at various national and international platforms. Today, we are proud to have him with us, and he will share the pulse regarding the use of his device known as BHEX. Welcome, sir.
Thank you, Dr. Nitesh. Thank you, Vishal. Thank you, Jaipur Ophthalmology Society. All friends in Jaipur, Viru, RK sir, Harshul, and many others, Ankur. The list is very long. So I'll be talking about the BX Pupil Expander tips and tricks, basically pearls and pitfalls. And thank you for the wonderful introduction. I do have a financial disclosure in the terms of my interest in the BX Pupil Expander and the company. And I gratefully acknowledge the videos contributed by Dr. Neto Rosatelli from Brazil, Dr. Deepak Magur, our own, Dr. Ayan Mahanta, and Dr. Ajay Paul. And of course, thanks to Vishal, who's announced it earlier, the BHEX has been recently registered and listed with the US FDA. So we are traveling across the seas now. So in August this year, we conducted a survey, and it was heartening to see that the BHEX Pupil Expander, in a country where cost is a huge factor, the BHEX Pupil Expander was as popular, in fact, a little more popular than the IRIS-UX among the responders. So that was very heartening and gratifying to see. And we were elated to see that the number of the happy users were 91% of the users were happy. But then we were a little concerned about the 7% of unhappy users, and we wanted to look into what exactly led to the unhappiness. So we analyzed the results of the survey, and we checked what did the happy and unhappy users do differently. So we checked what instrument did the happy users use. We found that 77% of them used the BHEX 23 gauge forceps, which is what is recommended. And unfortunately, what the unhappy users did was they used the Sinskey hook despite the recommendation in about 87%. So we went further and checked, there is a recommendation to stretch the rigid pupil before using the BHEX. So we checked how many of the happy users did that, and we found that almost 67% did that. For with the 67% of the happy users did that. Among the unhappy users, a large number, almost 50 and 63%, did not know about stretching of the pupil or did not do it. So that prompted me to probably build a presentation on tips and tricks. So BX structurally is basically a hexagon with notches and flanges. We got strong flanges, we got thin flexible notches, and there are tabs for holding. The BX 23 gauge forceps is what is recommended. It's got a short curved stock. It's got serrated jaws, and the jaws open perpendicular to the plane of the squeeze handle. Now, it's important for you to check that it's an original BHEX or a genuine BHEX. There are a lot of fake ones going around, and in fact, one particular distributor sold a pair of scissors, VR scissors, as a BHEX forceps, and we had huge issues with that. So how much and where to inject viscoelastics for iris hooks or pupil expanders? There's a natural tendency as soon as we make the paracentesis to inject the viscoelastic in the anterior chamber, to inflate the anterior chamber to see how well the pupil is expanding. Now, unfortunately, that kind of plasters the pupil onto the anterior lens capsule. It would be better to inject a little bit of viscoelastic under the pupil margin so that the pupil margin is elevated, and that creates space for the device. So we keep the anterior chamber underfilled with viscoelastic. Iris bowing helps in hooking the iris and tucking of the flanges, and overfilling would push the iris against the lens capsule. So this is how we do it. A little bit of viscoelastic just so that there is no endothelial touch in front of the iris, and some part of it goes under the pupil margin to just lift it off from the anterior capsule so that the passage of the flanges is much easier and smoother. So in 2005, Chang and Campbell told us something very new, that non-elastic myotic pupils, the IFIS, unlike the non-elastic myotic pupils, the IFIS pupil immediately snaps back. So that led us to understand that the small pupil is of two types, elastic or non-elastic. So the elastic pupil is like a rubber band, it's stretchable, and any pupil expander would work. Whereas a rigid or a fibrous non-elastic pupil is tearable. It's like a string. It's not stretchable. So you need a strong and bulky expander to kind of tear it, or you need two Kuglen hooks to tear that fibrous ring. So the choice of the pupil expander would depend on how you wish to tear the rigid non-elastic pupil. That's what it boils down to. If you're okay to do it with two Kuglen hooks, you have controlled tears and a round pupil. You could use the BHEX, which is hair thin, 75 microns, occupies less space in the anterior chamber, and allows you a lot of freedom for movement of instruments in the anterior chamber. If you want to do it with the pupil expander, well, you'd have poor control, slightly asymmetric tears. You could use it, the Malugin ring, the APX, or the I-ring. These are bulky devices, and they occupy more space in the anterior chamber, and they obstruct movement of the instruments. There's a good way to check the elasticities of the pupil before we start. So as soon as we make the paracentesis, inject BSS, inflate the anterior chamber. If that pupil expands momentarily, you know that's an elastic pupil. That would expand to that extent. But if it's a rigid pupil, no matter how much of BSS you inject, it will not really budge too much or minimally expand. That's when you know you need to stretch that bimanually and kind of tear that fibrous ring so that now it is more expandable, and you can use any device which you need. So what matters most is the elasticity of the pupil and not the size. I would repeat, it's the elasticity of the pupil which matters and not the size. So let's look at this wonderful surgery by Dr. Neto Razzatiri, a good friend from Brazil. That's a 1 millimeter pupil, and it has been rendered elastic by removing that fibrous ring. He did that very neatly and elegantly, and see that though he's using a bimanual technique, the pupil has now become elastic, and you can still tuck those flanges. So when you tuck those flanges, now you get a 5.5 millimeter pupil. You did not use any stretching, but the pupil was rendered elastic by just removing that fibrous ring. So it's not the size of the pupil, it's the elasticity of the pupil which matters, and that's what we need to assess when we start the surgery. So if the pupil is rigid and less than 4 millimeters, I always recommend we need to stretch it bimanually before using the BX. The BX is not a muscle man device where it could tear the fibrotic ring. There is a little bit of trade-off between pupil expansion, between the strength of the device and the mechanical strength and what it can do. So a thin device will obviously not be so mechanically strong. How big do you want the pupil to be? Now, from the iris hook days, we wanted to stretch the pupil and get a very big view. Though sometimes we choose to do a surgery in a 4.5 or a 5 millimeter pupil, we trust our skills. So aren't we all skilled to perform phaco with a 5.5 pupil, which will not get smaller? So if you're assured, the BX gives you an assured 5.5 pupil. So where's our problem? We would sometimes choose not to use a pupil device and do a 4.5 or 5 millimeter pupil without, be a Braveheart over there. So let's look at this by Dr. Deepak Mego, a rigid pupil, pseudoexfoliation, and a hard cataract. That's a pretty hard cataract. And let's see if a 5.5 pupil we can get away with a 5.5 pupil. So that's a 5.5 millimeter pupil. And you can see as he is chopping that cataract, it's pretty hard. So all we need to do is chop that cataract into very small fragments so that you can easily eat up each piece and remove it. And then implant as with IOL and removal of the ring is very easy. In a case of intraoperative miosis after capsulorhexis, what we need is a very thin device that can be held and guided into the space between the capsular rim and the iris in a controlled manner without engaging the capsulorhexis margin. That's our biggest concern. So the Malugin ring used with an injector is more remotely controlled and is more likely to engage the capsulorhexis. The BX is held with the 23 gauge forceps and its uniplanar and open notches does not engage the capsulorhexis and provides instant confirmation as you engage the pupil margin. Let's see a case of intraoperative miosis. And that's Dr. Deepak Mego again. I started off with a fairly reasonable size of pupil. The pupil came down on him during the surgery. Just inject a little bit of viscoelastic under that pupil margin. And as you tuck those flanges, you can draw it to the side, to the limbus, and you had instant confirmation by no resistance that you have not engaged the capsulorhexis margin. So you're under direct visualization, you're tucking those flanges, and you have instant confirmation as you move back to your comfort zone to complete the surgery. And look at this. This is a surgery, a femtosecond laser assisted cataract surgery by Dr. Ajay Paul. The pupil was 4.1 to start with. So he adjusted the capsulotomy and a diehard fax surgeon. So he reduced the pupil, the size of the treatment area, made a small capsulorhexis, and he got away with it. But then, as we know, after the femto procedure, the pupil comes down. So now he chose to use a BHEX device. The same principles, injected viscoelastic under the pupil margin, and then tuck those flanges, and now you are back to your comfort zone. And it's very important in flax because the capsulorhexis margin may not be as strong as a manual capsulorhexis. Though that's probably contested now by flax surgeons, we'll not go into that debate. And then that surgery became pretty easy. And removal of the BX is very easy. It's one of the easiest devices to remove. We'll come to that shortly. So there's some more pearls that I'd like to share. It's useful to fixate the globe with a side port instrument that helps in manipulation, and the eye does not move away from your microscope field. That way you have full control over the situation. And if you need that, you cannot access a side port because of a high nasal bridge or a deep set eye, you could rotate the eye. If it's a patient from the topical, you could ask the patient to rotate the eye or just turn the eye, and you will gain access to the side port to introduce your BX 23 gauge forceps. Now let's see how do you use a side port instrument. This is a kind of spear-like instrument which Dr. Deepak Mego is very fond of. You could use any device. You could use a cannula also, or a side port, second spatula, lens spatula, whatever you choose. But that stabilizes the eye as you initially, in fact, when you're using a BX forceps, after some time, you learn to control it, so you don't need that side port device. But if you're using a lot of hydro implantation, like some of our colleagues are used to, you could use that also as a side port instrument. In the case of a shallow anterior chamber, you need a thin device. So BX is 75 microns throughout. The corners of the Malugin ring is 0.9 millimeters. That's more than 10 times the thickness of the BX ring. And we know the mid-peripheral antechamber is much shallower than the central antechamber. The central antechamber is 3 millimeters. The mid-peripheral would be 1.5. So it could be a very tight situation with the Malugin ring lying in the antechamber. It could knock the endothelium and we could be in trouble. So let's look at this very shallow antechamber and intumescent cataract done by Dr. Deepak Magur. Wonderful surgery. And you see, and there were a lot more other complications, but you have full control, and there is no question of using a 23 gauge forceps. There's no question of touching the endothelium. Just a little bit of space in the antechamber is good enough to do that tucking of the flanges. And here there's a CTR also being implanted. And then once you have done that, it's very easy to remove the BHEX pupil expander. It's important not to dislodge the BHEX, or for that matter, any pupil expander in the process of the surgery. So we need to chunk the nucleus into very small fragments, attempt in the bag delivery of the trailing haptic of the IOL. Now, if the trailing haptic is not delivered in the bag, pushing it against the pupil margin will dislodge the BHEX, or may dislodge the BHEX, because the BHEX is not really pinching the pupil margin. So what we can do is push or pull the outer edge of the trailing haptic in the IOL plane, so that we cause flexion of the opposite or the leading haptic optic junction against the equator of the bag. And that creates room for the trailing haptic to negotiate without contacting the pupil margin and the BHEX complex. Now let's look at this. Now, if you can do it in a single pass and implant it in the bag in one go, nothing like it. But in case you just don't do that, and you, what happened to this? This video is not playing. Okay, we'll skip this. Let me just see. I'm sorry, this video is not playing. So if we, now this is a situation where you have dislodged a ring into the bag. In fact, the surgeon didn't notice. This is Dr. Ayan Mahanto. It's a wonderful surgery. We need to see complications also. But if you have managed to put the ring back into the bag, you can always just hook it up, bring it into the antech, some part of it, any part of it. And this is an older version of the BHEX, and you can just chop off the snippet in anywhere and just hold that ring. And it's a very thin device. You can just bring it out very atraumatically. Now, this is removal of the BHEX. The simplest technique I feel is hold one of the flanges which is close to the main incision, advance it centrally, untuck the two notches on either side, and then just draw it out. The trailing notches simply disengage spontaneously. You really don't have to do too much. You could remove the BHEX through a 1 millimeter side port also. Just disengage the notches and draw it off. This no pupil expander can do, and this could be very useful in a tight situation where you have iris prolapsing through your side port on the main incision. In an IFIS case, this could be very helpful, or in a very shallow antechamber. So which would be your pupil expander would depend upon your choice. If you want easy to insert, engage and remove through a small incision, and something to hold the pupil expanded, which is unobtrusive, BHEX can do that all. I'm sorry, this is moving in auto. If you would choose to tear a fibrotic pupil, then you have to use a pupil expander, which is pretty strong, like the Malugin or the APX. But you could do that alternately with 2 Kuglin hooks very easily and in a very controlled manner. So BHEX can't do that. So for that, you need a preparation, and you need to stretch that rigid pupil with 2 Kuglin hooks. These are a few of publications, 2014, mine in JCRS, and then mine in IGO in 2017. And this is more for vitreoretinal surgeons over here. This BHEX was used in a series by Dr. Debdulal Chakravarti. Now he's got a series of 46 cases, he told me last week, and he's going to again publish in some leading journal. I recommend for those who are interested, could look up these 10 tips for phacoemulsification on small pupil. It's available on eophtha.com. And thank you very much once again, Jaipur Ophthalmological Society and friends in Jaipur, for this very kind invitation. I'd be happy to answer any questions now, later, anytime.
Thank you, sir. Thank you, Suven sir, for the excellent talk. And Dr. Suven sir is one person who is really, married to his passion, and that is evident if you go to his WhatsApp DP. Actually, he has, his pic is posted, is posted in the frame of BRAX pupil. So,
that I owe to Mukesh Porwal, our good friend from Rajkot. Mukesh is again very innovative with his designs and flyers and all. If you see, So Mukesh is a good friend from JIPMA, and he did that for me. He asked me for a picture of the ring. That's very kind of him and very sweet of him.
So I'll have the first comment from Dr. Harshul. Dr. Harshul, are you there?
Yeah, Vishal, I'm there.
And because the first comment from him, because he's a great fan of, he swears by Malyugin rings. So I'll just, a frank opinion, honest, his version of what he uses and why does he prefer Malyugin ring more than B-Rex, just to, interact more on this topic.
No. So
if I'm right, that you use more Malyugin than B-Rex.
Firstly, congratulations, Dr. Suven, for wonderful presentation, and congratulations on USFDA approval of your brainchild of BX ring.
Thanks,
and we all know that Dr. Suven performed the second live surgery of BX ring in Jaipur Ophthalmic Society conference. Yes. If Dr. Suven remembers that.
Of course.
It was a wonderful surgery, and that time the device was different from what it is presently now. And now it has been modified by Dr. Suven, taking all the feedback from all the surgeons. So I'm also shifting now to BX ring. In almost many cases, I'm using BX ring because of its thinner profile. It definitely has the advantage that it can be used in cases which has shallow anterior chambers and pediatric cases. And moreover, I always use 1.8 millimeter incision, so it's very easy to insert this device through 1.8 millimeter incisions.
Oh yeah.
Can you hear me?
Yeah. Sorry, my screen was shared.
So the only concern, Dr. Suven, was with the flexibility of this device. Can you make it a big stiffer, this device, little bit more, so that we can get a 6 or 6.5 millimeter pupil and it's more rigid?
Good question, Harshul. Actually,
can this be done?
You have put actually two questions together. One is you want a more rigid device and a stiffer device, and you're also asking for a larger device. Now, both we've been through prototyping. Actually, it's a trade-off, like I said, with the device, the thing that we use. If we increase the thickness even marginally, the flexibility drops hugely. Okay, so this is 3 mils thick, 75 microns. If we go up to 125 microns, it comes in, this particular thing can be made in that kind of thickness only. You cannot get in, it's like IOLs we get in 0.5 diopters. So the material also comes in sheets like that. So I have actually, in fact, I have thicker versions, and I tried them on my own cases, and we found that to be very, very stiff. And actually, what is stiff inside the eye is very different from what it's outside the eye. So inside the eye, when you start using it, it becomes a little too stiff for comfort, and it's not that flexible. See, the earlier things that I was using, my prototypes, which I did in Jaipur, which I did live surgery in each place. Lovely surgery that we had. Those were my handmade prototypes. That was made from 50 nylon. Okay, so but this is a different material. It's polyimide. It comes in sheets. So there is a restriction over there. Now that is one problem. So after a lot of hit and trial and this and there, we came down that we accepted that trade-off, that we cannot make it any stiffer because it will become difficult to handle. Then we come to the size. Now, like I said, the size is only a mental issue. Harshul, I know you are a damn good surgeon. You would any day take up a 4 or a 4.5 pupil. If the iris does not start prolapsing immediately, you will do like a breeze. You will do a 4.5 pupil easily. Correct? Because now we've got excellent machines with excellent fluidic controls. Surgeon skills have improved hugely. So we realize that 5.5 is a good size. And if you are sure that it's not going to come down. See, with a 4, when you start off, you have still got the threat that it's going to come down. And still you go ahead and do it because you trust your skills. But here it's a 5.5, which is not going to come down. So we don't have a problem. And the other technical problem that is there, if I make it, say, 6 or 6.5, now if it's a very small pupil, let's say it's a 2 millimeter pupil, you tuck the first flange, the entire device moves to the angle. Now retrieving the other flanges becomes a challenge. So if you start with a 4 millimeter pupil, it's not an issue. But if it's a 1 millimeter pupil or a 2 millimeter pupil, as soon as you tuck because the entire ring has now moved kind of, some part of it is moved centrally and the rest will move absolutely to the angle. So that can cause trauma to the angle. In fact, I had a 7.7 millimeter and a 7.5 millimeter version, which I found difficult. In fact, I had a fair number of 7.5s, which was a weaker version also, but it was difficult to handle that. So, I mean, after a lot of hit and trial, we have reached here. But if we feel that there is a demand, because prototyping is very expensive, if there is a demand, we can go for a larger size. We will look into that. We will look into that.
Sir, my next, I'll invite Dr. Virendra to make a comment on this, and a small query also to him.
Thank you.
Dr. Virendra, in your practice in general, how frequently you feel the need to use a pupil expander device, whether it is B-Rex pupil, whether it is Malyugin ring? Dr. Virendra?
It was initially, I'm listening.
Yeah,
and
and
I agree
the
with
extension to
Suvan
that
perfectly
question is
that
because
the
I have
pupil
seen
which is
you
fixed
and
size
Dr.
of
Pankaj sir.
5.5.
So because the point here is that I have
Not
seen
using.
you and Dr. Pankaj sir, using the iris manipulation, and you just retract the iris on one side and complete the case anyhow. So what is the general? I'm not equating your surgical caliber to everybody else's, because novices might require these devices. But in the last year, how many cases do you remember using that pupil expander device?
Yeah, I agree. First of all, I agree with the Suven, and I must congratulate him for a innovation of a very great help. And now getting FDA approval means it will be used all over the world. It is a big achievement for India, for Suven, and I think we are lucky when Suven was in Jaipur and he did a live surgery from our center when it was not approved. So he asked for ethical committee kind of approval. We had our own ethical committee, and we found that it can be used for a live surgery. So thank you, Suven, for that. The second thing, Vishal, you asked that how frequently I use. I definitely not use it much often, but definitely it is of big help, particularly when patients are coming off the, who are on the, what you say, for treatment for prostate, because the pupil does not remain of the same size. It keep on fluctuating. And in those cases, if you have some expander like DX, Malyugin, or whatever kind of you prefer, it is a big advantage, because otherwise you will remain under tension. Otherwise, if the pupil is not very fragile and it is having a 4.5 plus, I think I am very comfortable without using anything. Not using
Vishal?
any pupillary expander device, be it hooks or rings. But if it is a small pupil, if intraorally it becomes small, or if it is a pupil which is not allowing you to complete the surgery, there should be no hesitation in using pupillary expander device for your safety and comfort of the patient as well as the good outcome.
Can I have a word, Vishal, over here?
Yes, sir.
I do.
Yeah,
see, Virendra's skill cannot be compared with the average surgeons. Okay, Virendra started hydroimplantation of IOLs long before people were doing it, and he was doing it in pediatric cataracts. He's presented in ASCRS. What do you say, Virendra? So his skills you cannot compare. So second thing is, now if I have a cataract, let's say I have a cataract, and if Virendra is doing my surgery, or Harshul is doing my surgery, I know they are very skilled. And if I let's say I am on tamsulosin or not, and my pupil is 4 millimeters, I would tell Viru Bhaiya, Harshul Bhai, ek kuch to iris kam se kam use kar le yaar.
They will be happy to use.
So no,
I will say better safe than sorry. I trust your skills. There is no doubt about it. But when it comes to our own, we have different standards. But when it comes to the patient, we might be taking a little risks. That I think is a little bit of double standards.
Okay.
No, 100% agree, Suven.
Just
100%
last
agree.
one thing, can I add, Dr. Vishal?
Sure.
See, when we were in the initial stages of our career, we never used to use any kind of hooks or anything. We used to do surgery with 3 millimeter, 3.5, 4 without using anything. But as we became more skilled, believe me, I don't think twice before using, either BHAX or Malyugin or iris hooks in patients who have 3 millimeter pupil. Because now we use multifocal lenses, trifocal lenses, toric lenses in this pupil, small pupil. And at the end of the surgery, we need a perfect rhexis of 5 millimeter size covering the optic nicely. We don't want a rhexis of 4 millimeter, 3.5, which will fibrose 6 months after the surgery, So now our threshold has become very low in using these expanded devices. You never think twice. If you see pupil 3 millimeter, straight away put expander, as Dr. Suven said. Yeah.
Yeah, actually, if you land up in a complication, the time that you're
Yeah.
saved in doing one surgery, 3 millimeter pupil or 4 millimeter pupil, if you land up with a complication, you've spent a lot more time salvaging that case. And then apart from the results, that may be a big
In
question.
fact, you can prevent complication.
Absolutely.
No, in fact, you can prevent having complication. When you have pupillary expansion, you will prevent complication.
Okay. Any other comment from the panel? Or we can move to the next topic.
I just wanted to ask the cost for the general public and can it be reused? Dr. Suven. Yeah, Dr. Ankur here.
Yes, Ankur. Nice to see you all. Yeah. So yes, two good questions. Well, the cost is, if you buy a single device, it's 1,800 plus GST. That works out to 2,000 bucks, 2016. If you buy 5, now we have kind of incentivized volume purchases. So if it's 5 rings, it's 1,500 bucks. If it's 10 rings, it's 1,450 and GST, so on and so forth. So if you're buying 100 rings, it comes down to 1,360 or something like that. So we are incentivizing volume purchases, which was not there. That's one aspect. Coming to reuse, well, it is sold as a single-use disposable device. Okay, that is how it's sold. Now, India is kitna deti hai. We are that way. People we started with iris hooks. People used to keep iris hooks in the formalin chamber when ETO sterilization was not so widely available. The people have done a lot of things, but we have moved away from there. Like Harshul said, we used to do everything. We used to do a lot of things in our training days when we didn't have the resources, but things have changed. Our standards have gone up, and we're trying to reduce our threshold for safety. So the problem with reuse is it alters the mechanical properties and the shape. So you might have an intraoperative breakage of the ring, or you will have a twisted ring. So it's a uniplanar ring. Then you might not get the best results. It's not that it doesn't work. It's one of the hardest plastics. I mean, it's one of the most tolerant plastics on the face of Earth. So people have used it repeatedly. There are people who make very tall claims as to the number of times they have used. I don't want to go on a public forum and say that, but because it's counterproductive for me. So, but yes, it's sold as a single-use device, and I would recommend that it be used as a single-use device. Please pass on the costs to the patient. The patients happily are very happy to pay a price of 1,500 bucks for a device if they know that it affects their outcomes hugely.
Yeah, that I agree. But a lot of
that is easily said and done.
Yeah, a lot
just want a package.
Exactly. That's what I was saying, because a lot of youngsters, when they are starting up their practice, they need more of kind of devices to help their practice.
I will really
plus the financial constraints are also there.
No,
Vishal, I know it's easier said than done when you say that, but actually I have been billing my patients for a hard cataract, for a hypermature cataract extra, and I put it on paper. For a small pupil, actually small people, I do not bill them for the device. I bill them only for the skill, because the device comes free. Because there will be a conflict of interest over there. So I don't bill them for the device at all. The device comes free. I just bill them for my surgical skill, additional skill. So wherever I'm using additional skill, I tell them I have a monitor in my clinic where I show them that the pupil is not dilated, and this is what I'm going to use it for. They're happy to choose another surgeon who would do it for less, but I have never ever in my many years of that I've been doing phaco had a patient complain. In fact, they gladly appreciate that. And then when you tell them that it's a complicated situation, they're willing to accept the results. They are willing to accept it's a hard cataract. They're willing to accept that SK and 2 lines short of vision on the first post-op day. It's easier to convince. Try it.
Yes. Point well taken, sir. Okay, now we move to Dr. Manish Bapai, sir, for his presentation. Can you share your screen, sir?
Good evening, Dr. everybody. Amish? Can you hear me?
Yes, we can hear you.
Yeah. So on personal note, I also like to use BHEX ring, or that is the, other than iris hooks, that's the only device that I've used for pupillary expansion, and it's excellent device. And I've used it 2 to 3 times each device. So, that's a personal experience.
Thank you.
Yes, sir. Coming to my talk, I'll be talking about the claw novel intraocular foreign body forceps that I happen to design. I have no financial disclosures.
Sir,
So,
I can just give a small introduction about you before you present, if you allow me.
Sure, please go ahead.
Yeah, I would like
you can
to
upload
welcome...
your presentation. We are just seeing your desktop here.
Yes. So just to give a brief details about Dr. Manish Bapai sir. He is a multi-talented person who is practicing cataract, refractive and vitreoretinal surgery in Nashik since 2005. He did his fellowship in vitreoretinal surgery in 2005 from Shankar Nethralaya, Chennai. And his innovation, the claw, a novel IOFB forceps, has received Innovation Award of Maharashtra Ophthalmological Society at MOSCON, Pune 2017, and Rakesh Sharma Memorial Award in Trauma Session at All India Ophthalmic Conference, Coimbatore 2018. The best part is that his device was extensively used in removal of shotgun pellets from eyes of victims of pellet injuries in Kashmir Valley in 2016, and is still used extensively throughout in India. His other innovation is Aspiration Scraper that also received the best paper Dr. S. Natarajan Award in vitreoretinal surgery session at All India Ophthalmic Conference Indore 2019. So I would welcome Dr. Manish Bapai sir to please go ahead with his presentation.
Thank you. Thank you, Dr. Amit. Thank you for that kind introduction. And at outset, I would like to thank Dr. Vishal and my friends, Dr. Abhishek, RK sir, and Harshul Bhai. It's a pleasure to be talking to you all. I'll be talking about this, the claw, the novel intraocular foreign body removal forceps. I have no financial disclosures. So penetrating ocular injuries are associated in a significant number of patients with retained intraocular foreign bodies. And it's an important cause of visual...
We can't see your presentation.
You can't? Surprising. Okay, let me shut it down. Okay. Just tell me if you can see it. Just give me a second, please. Let me...
Sure, no problem.
Can you see it now?
Sir, it is visible now.
Yes.
Yeah. Okay. Wonderful. So, as I said, so I have no financial interests. Coming to introduction, penetrating ocular trauma is associated with retained intraocular foreign body in a significant number of patients. It's an important cause of visual morbidity and blindness in working age population, and a lot of with large majority of males. The 3-port pars plana vitrectomy with internal removal of IOFB is a standard procedure now for removal of posterior segment IOFB. And we have shifted from 20 gauge to 23 and 25 gauge vitrectomy, which has led to even better visual outcomes than we used to have before with the improvements in instrumentation. Most of the foreign bodies are iron foreign bodies, so various IOFB magnets and various types of forceps are used for removal of smaller foreign bodies as well as metallic foreign bodies. However, removal of large spherical non-magnetic foreign bodies like shotgun pellets, stones, or glass fragments remain challenging in majority of cases. So how the journey started was, this was a patient who had fairly large glass foreign body, which he received in a lab accident. And intraoperatively, however hard I tried, I could not remove the foreign body. The LPFC would flow over it. I made a snare using 4050 Vicryl, and I could lift it up to the pupillary plane, but could not hold it there. Before I could remove it, it would fall down. And I had to refer this case to Shankar Nethralaya where they removed it with great difficulty. But that got me started thinking as to we should have something. And my father, who's a urologist, when we were discussing that day about this particular case, he suggested, why don't you use something like a Dormia basket that we use for removal of ureteric stones. And that was how the journey started. So initial prototype actually made was a basket design, but we realized that it is little difficult to handle in the vitreous cavity, because you have to use bimanual technique to engage the foreign body. So instead we decided on this claw type of device. This is a forceps which has a retractable claw-shaped prongs. It has a handle which is made of titaniums and retractable prongs which are made of nitinol. Nitinol is an alloy of nickel and titanium with excellent shape memory and pseudo-elasticity. What it basically means is that it can distort a little without causing permanent damage to the prongs. The outer circumference of metallic cylinder is 19 gauge, and the prongs can extend or they can open up to 8.5 to 9 millimeters without distortion. So how we use it is the claw is fully retracted, the prongs are fully retracted in the metallic cylinder while introducing it through the sclerotomy, which usually has to be enlarged because we are using 23 or 25 gauge sclerotomies nowadays. And in that case, in those cases, we open the conjunctiva, enlarge the sclerotomy to the required extent, and the device is inserted in the vitreous cavity. It can, as we approach the foreign body, we gradually open the extend the prongs to the extent required, and it can hold a large foreign body without slipping. The distal ends of the prongs, as you can see, are slightly bulbous and they are less traumatic to retina. So it's the slider on the device which can be used to extend and retract the claws. Let's look at some clinical cases. This was a 42-year-old male patient who had penetrating trauma with stone at no PL at presentation. There was a large scleral tear and diffuse hyphema occluding the fundus view. This is the CT scan where we can see how large the foreign body was, and the eyeball had collapsed around it. It was a stone foreign body. So intraoperatively, after scleral repair and lensectomy and hyphema removal, vitrectomy was done, and the device is introduced, and it is used to pick up the stone, and the stone is held effectively in the pupillary plane, while other hand is used to make a very large limbal incision. It is almost 180-degree incision, and but throughout the device is holding the foreign body securely. And then I had to use superior rectus forceps to get the foreign body out. No other forceps could hold it. And here we can see such a large non-metallic or non-magnetic foreign body could be removed. The foreign body was almost 10 millimeters by 5 millimeters. The second case is that of a glass foreign body, which had, the glass was through the glass was that of spectacle of a patient who was involved in road traffic accident. There was dense vitreous hemorrhage, and actually we could not see the foreign body in the ultrasound pre-operatively, and it was a bit of a surprise to find the glass piece in the eye. So the thick vitreous was dissected and cut, and this was the incarceration site. Then the chandelier light was used, and here the prongs are extended and the glass piece is lifted from the retinal surface and is brought onto the iris. There the glass piece was placed there safely, and then I introduced the claw through the limbal incision and held the glass piece securely before removing it out of the eye. The next case is contributed by my good friend, Dr. Sharad Bhomaj from Sangli, where Dr. Bhomaj is using this forceps to remove a large stone again. So this was a patient who had a glass foreign body and, the stone foreign body. And Dr. Sharad is lifting the foreign body by extending the prongs, and it is brought out by handshake technique through the scleral incision. Again, we can see how large the foreign body is. It is almost 7 millimeters and irregular in shape. The next video is by Dr. Sangeet Mittal. This is a relatively small foreign body, and he uses bimanual technique very frequently. So here the foreign body is deeply embedded into the retina. He has done complete vitrectomy, and foreign body is released from its capsule. Once the foreign body is released, he has done sclerotomy, additional sclerotomy. The magnet is used to lift the foreign body in midvitreous cavity, and the claw is then used to remove even a relatively smaller foreign body. And then the sclerotomy is sutured. So as already described, it has been extensively used in pellet trauma. So we all know history of unrest in Kashmir in 2016, where the pellet guns were used for crowd control, and it led to extensive ocular injuries due to pellets. The pellets are they are made of lead and usually spherical in size, and they are marked as BB, which is the largest size, and shot number 1 is smaller than shot BB, and shot number 9 is smallest. And their size varies from 2 to almost 4.5 millimeters. These pellets usually have smooth surface, and surgeons who are operating, including Dr. Natarajan, who has largest series of this pellet removal cases, they initially found very difficult to hold the foreign bodies while removing it, and it was taking a lot of time. But eventually the claw was used with quite effectively. These are some of the clinical photos of pellets being removed from the eye, and this is an intraoperative photo which has been given by Dr. Natarajan. Here he has used additional sclerotomy, and we can see the pellet being held after removal from the eye. So coming to discussion, the instrument design was initially based on concept of Dormia basket, which is extensively used for removal of ureteric and salivary stones. However, the difference is the stones are spherical in shape, and they are in enclosed spaces like ureter or salivary duct. While when we are operating on the in a eye, in a vitreous cavity, it's a fairly large and open space where the foreign body can move in any direction. So it may be difficult to engage these foreign bodies if they are moving constantly in some on the retinal surface, and that can cause trauma. So the claw design enables surgeon to hold the foreign body securely by approaching in anterior-posterior direction and picking it up directly from retinal surface. The irregular shaped foreign bodies can be held better by claw design as compared to basket design. Snare and loop designs have been described by various authors. However, large spherical foreign bodies can be difficult to hold, as I showed with my own experience, and they tend to slip, and they can cause the retinal trauma because of repeated slippage of foreign body. And in such cases, we can use claw. And in cases of glass foreign body, as we saw, there have been other designs, other forceps that have been used. So they can cause crushing or splintering splintering the glass foreign bodies, which does not happen with this particular claw design. So in conclusion, claw is a novel design which can securely hold and remove various sized non-magnetic and non-metallic foreign bodies in ocular trauma, and as it has been proved, it is a valuable tool in the hands of vitreoretinal surgeons who are involved in management of war zone injuries. So this is what the claw has helped me from failure to remove this glass foreign body to removal of this very large stone foreign body from the eye. And it has got me accolades on the way. This is our publication in IJO. And I would like to thank Dr. Natarajan and Dr. Shanmugam, who have contributed in data, and they have used extensively for pellet removal in Kashmir. Mr. Mateen Amin of Epsilon, who took me seriously and designed the foreign body forceps based on my discussions with him. Dr. Sharad Bhomaj of Sangli and Dr. Sangeet Mittal from Punjab for sharing their videos, being kind enough to share their videos for my presentation. And I thank you all for your invitation and kind attention. Thank you.
Thank you, Dr. Manish. Great innovation, a very helpful innovation, especially in pellet injuries in Kashmir. And I always, Dr. Manish has a, very busy cataract and VR practice. And we always meet at the annual ASRS conference. And I always ask him, Bhai, itna time kaise nikalte ho? How do you make time for, these innovations and academics? It's really a commendable job he does. So now comments from the panel, Dr. Kothari. Dr. Abhishek, have you used this? Any views about the device?
Yes, Vishal, I have this device, and Dr. Manish has already said it, but I find it most useful for irregular, thicker, and round foreign bodies, because there our routine foreign body forceps fail. They don't have a grip, the foreign body slips. For flat, these chisel hammer injuries, I still prefer the end grasping forceps because it is easy to align the metal along its long axis with them. And it's a little more difficult to do with this forceps. But for the larger foreign bodies, the non-magnetic foreign bodies, there really is nothing better than this, because with this, once you have once you grasp the foreign body, then it doesn't slip. There's no chance of slippage or of it turning around unexpectedly. So that way,
have you used the basket foreign body which we used to have? And how do you compare the grip with this and with the basket foreign body?
Oh, this is much better. This is much better than the basket.
Okay.
I have the basket foreign body forceps, but I stopped using it.
Dr. Ajay, any comments? Any personal experience on the forceps?
I have actually used Manish's this thing. Operated a few cases in Srinagar where we have removed foreign bodies, pellet foreign bodies with the forceps. The unfortunate thing that happened is these claws are very delicate. So one of the assistant, while cleaning them, he bumped the instrument on the trolley. So the claws got bent, and I have sent it to Epsilon for returning it. But yes, it's a wonderful instrument because it opens up more than 6 millimeters. I think, Manish, is that right? It's more than 6.5.
Up to 8.5 to 9 millimeters without distortions.
Yeah, so it was very useful. Otherwise, as Abhishek said, for other foreign bodies which can be held with the end gripping forceps, we tend to follow that. Yeah.
I totally agree. But I also want to add that the video, sir, you showed about Dr. Sangeet Mittal operating on that case, I would have preferred to, remove it with the foreign body magnet because that was small in size and magnetic. But so that it's a personal preference. Yeah.
Yeah.
So do we have any other comments on this talk? Okay, now we'll move to the next talk. Dr. Jagdeep, can you share your screen, sir? Can we have the kind introduction of Dr. Jagdeep Kakadia from Bhavnagar?
Thank you, Vishal. Now I welcome Dr. Jagdeep sir from Bhavnagar. It's my honor to introduce him. Dr. Jagdeep has done almost 60,000 plus cataract surgery and almost 6,000 plus refractive procedures. And there is a long list of his research work, but it would be quite impossible to elaborate all due to paucity of time. So I just try to concise them. He was first to develop Indian ophthalmic chair unit in 1989 at Plantech Medical Systems, Ahmedabad, with which we all are familiar. He was first to develop the hydrophilic acrylic foldable IOL in India at IOCare in 1994. And he has developed his own homemade excimer laser iLace 2020 and have used it over 4,000 patients. Also in Corona pandemic, he developed a UVC device named Coronash, which can kill coronavirus in mucosa of nose, throat, and paranasal sinuses. And last but not the least, he developed 0-degree stereo coaxial illumination system known as OmniGlow, which can be attached to any microscope. And today he will share the experience with the same. So I welcome Dr. Jagdeep sir. Welcome, sir.
Thank you, Dr. Virendra Agarwal and Dr. Vishal for inviting me to this prestigious webinar to speak about OmniGlow, my homemade stereocoaxial red reflex device. And wishing you Merry Christmas and a Happy New Year. And at the outset, especially thanking Jaipur Ophthalmic Society for giving me this prestigious time slot to speak about my device. The name OmniGlow comes from omnipresent red glow. It's an acronym of omnipresent red glow, and I do have financial interest in this device because I myself make it. The story is that when I perceived the advantages and importance of stereocoaxial red reflex, such as glow and depth perception, excellent ease of doing capsular access without using the blue dye, the trench depth control, early perception of the posterocapsular rent, cortical cleanup, anterior capsule cleanup, and overall enhanced pleasure of doing surgery and the confidence, boosted confidence of the surgeon, I decided to buy a Lumira microscope for myself at the cost of Indian rupees 4 million. But my bankers rejected my loan, stating that your balance sheet is too weak and we cannot afford you a loan. So it was our 20th wedding anniversary, and I proposed to my wife, hi Sakhi, let us sell out our 40 vega of farmland to buy me a Lumira microscope, or let us sell 2 kilograms of your gold. And as you can understand, no lady would like either proposition. In 2006, I had made my own homemade excimer laser and saved her 24 kilograms of 24 karat gold. So this time also she said me, if you could make an excimer laser, why not a Lumira device for your microscope? And as Plato has said, necessity is the mother of invention. And when I saw these photographs on WhatsApp groups of African boys making their own billiard tables, I decided that let me make my own Lumira device. So I revisited Hermann von Helmholtz's 3 principles of coaxial illumination, and I decided that the principle A, if employed in the right proposition, would convert any microscope into a Lumira-like microscope. I also studied the principle of stereopsis enhancing optics, because the increase of glow decreases the stereopsis. The glow and stereopsis are vice versa. So you also have to enhance the stereopsis when you enhance the glow, so that you feel the anterior chamber really deep and all the structures in a very nice 3-dimensional enhanced view. And I also studied and revisited the principles of phase contrast microscopy described by Fritz Zernike, for which he was awarded a 1953 Nobel Prize in Physics, because the glow and the contrast again are in inverse proportion. When you increase the glow, the contrast decreases. This is Dr. Fritz Zernike and his phase contrast microscope principle. This is the electron transmission electron micrograph of tobacco mosaic virus without phase contrast, and this is with phase contrast. This is paramecium without phase contrast, and this is with phase contrast. So we had to increase the stereopsis as well as phase contrast while increasing the glow. And I got a very nice help from Dr. George Beko, who is the chair of physics at Moscow University, and got profuse blessings of Pujya Pramukh Swami Maharaj, my guru, to proceed in this project and this research. And after about 5 to 6 years of intensive working, I got my device patented, and this is the patent paper which I'm presenting to our current guru, Pujya Mohan Swami Maharaj. And the first device was blessed by him before we put it for friends. And after thinking a lot and doing a lot of experimentation with different optics and different light sources, we made a very small compact device which can be attached to the bottom of microscope, which will convert any microscope into a Lumira microscope. And OmniGlow is a light in itself, so it becomes the primary light source. Microscope's own fiber optic light becomes secondary or not necessary or redundant. OmniGlow lights are non-fusible halo LED, which is halogen spectrum light emitting diodes, and they have a guaranteed life of 50,000 plus hours. And at the rate of 8 hours a day and 300 working OT days a year, the lights will last for more than 20 years. So it's almost like for your career that the device will last with you. And the optics of the device are made of a cultured diamond-like very hard crystal plate. So it is unscratchable except by a diamond. Even with a screwdriver, you cannot scratch the optic. All optical coatings are extremely tough and are antifungal, and its paint is bactericidal and fungicidal. So even if there is an accidental touch, you consider it almost sterile. And it's almost like a lifelong and evergreen kind of an optical device. And so far we have made the OmniGlow for almost all microscopes, wide for Zeiss, for Zeiss 1FR. And as you can see here that there's always enough working distance under the OmniGlow. This is Zeiss 1FR Pro. This is OpmiVisu 150, OmniGlow with OpmiVisu 150. This is OmniGlow for Lumira 300. This is for Takagi OM5. This is for Topcon OMS 800. This is for Topcon OMS 90. And this is for APA Sami's APA Brilliant, which does not have a intensive ray reflex. And you can see here that there is always more than enough working distance. And the beam splitter, the camera, and the microscope handles, everything remains as is, where is, because OmniGlow gets attached to the bottom of the microscope. And if you want to use the same microscope for retinal surgery with a single bolt, you can remove OmniGlow and attach biome. And when you go for cataract surgery, you can again remove the biome and place the OmniGlow again. You can do it yourself. It's not not at all difficult. And we haven't observed any photic maculopathy or no additional extra chance of CME over a period of last 8 years, having done more than 100,000 eyes in about 120 installations with 120 surgeons in India so far. And so at a fraction of a cost, 15th fraction of a cost, you can convert your microscope into a Lumira-like microscope. And let us see it in video now. This is a small device which is detachable and attachable just by opening one screw. And you can detach it or attach it as many times as you want. In a conventional microscope, there's only one sweet spot for the full ray reflex, and that is usually tilting the eyeball lower and nasal of the patient. Whereas with OmniGlow, the red glow is omnipresent, homogeneous all around the pupil and in any position of the eyeball. This is a case of dense PSC cataract. And this is the beauty of the dense PSC cataract through OmniGlow. Capsulorhexis is always a pleasure. You almost never need to use blue dye for capsulorhexis except in white mature cataract. And because of phase contrast, you can so clearly very well see the capsulorhexis proceeding. The hydrodissection is always a pleasure, and you can see the fluid very, very clearly. And if you do hydrodelineation, you always see a golden ring reflex. The phaco chopping and the phaco fragmentation procedures are always a pleasure. And because of the enhanced 3-dimension view, enhanced stereopsis, you are always confident. Most of the times, I'm so confident, most of the times I use phaco probe to even remove my epinucleus and cortex because I see it so clearly. Blood behind the IOL is so clearly visible, and because of enhanced stereopsis, you are never afraid of going behind the IOL and aspirate the debris from behind. This is the debris from behind in a conventional light, and now this is through OmniGlow. You can see the interface of the viscomet so clearly that you can actually visualize till the point that the entire methylcellulose is out. This is the glow through small pupil, and even from a 2.1 mm, 2 mm or 1.5 mm pupil, the glow is always there in any position of the eyeball, any tilt of the eyeball. The glow never leaves you. Because of enhanced glow and enhanced stereopsis, you are always so happily and confident to enlarge the capsulorhexis and make it round. This is a PC rent, but with OmniGlow, you can perceive the PC rent so clearly. You can see the zonules in the pupil is very well dilated. The zonules are so beautifully visible. And it's very interesting to note that all the ghost reflections because of the plastic drape will go away completely as soon as we switch on the OmniGlow. So you're never bothered by and these are the multiple Purkinje-Sanson images given by OmniGlow. And it these are the two lights of OmniGlow. This is the light of my microscope. So on IOL surface and on cornea, they give me very nice smiley every day. And not only the smile on my face, but my wife and my daughter's face also, because they saved their 2 kilograms of gold. And you can also save your 2 kilograms of gold by having OmniGlow in your present microscope rather than going for a very expensive higher-end microscope. And this is a recent addition in which I have converted OmniGlow into UV glow. So the UV glow is the UV avatar of OmniGlow, which can be used for doing a C3R procedure. The conventional C3R machines, none of them have a microscope. Whereas with UV glow, you have a microscope to do the procedure, so you can visualize removal of the epithelium and the entire procedure, and record the entire procedure for presentation, as well as there's a lot of working distance. With all the other C3R devices, the working distance is only 50 millimeters, whereas with UV glow, the working distance is 200 millimeters. And also UV glow can be used to treat corneal infections, bacterial, fungal, and hypopine corneal ulcers can be treated with UV glow, and within 24 hours, the ulcer starts healing because all the organisms are killed, and the hypopine disappears in 24 hours. And by day 4, the ulcer has healed because the organisms have died. And this is a one-eyed patient with a very bad infection. This is from Dr. R.C. Shah, my research colleague from Bombay. And this patient was treated with UV glow and methylene blue eye drops, and the cornea started clearing. On day 7, the cornea from that was this. So it's possible to achieve disinfection of the corneal ulcer with UV glow. And this is another case of UV glow wherein a long-standing corneal, non-healing corneal ulcer could be treated, and within 7 days, the ulcer was treated from this condition to this condition. So wishing you very happy New Year 2021. I thank Jaipur Ophthalmic Society in general, as well as Dr. Virendra Agrawal and Dr. Vishal and Dr. Harshul Tak in particular on behalf of myself and Dr. Ramesh Shah. Thank you very much again for allowing me to present my talk.
Thank you, sir. Thank you so much, and an amazing innovation device. And I and Dr. Jagdeep were in a BOA session not long back, and his device really impressed me, and that prompted me to invite him to share his experience and his journey for the innovation of this device. So, quick comments from the panel.
I think it's a great innovation, Dr. Jagdeep. Congratulations. And what is the cost of this device, OmniGlow? And for it, does it change for different microscopes, or it remains same for all the microscopes?
No. Every microscope model has a different size and different shape of the optics. So I had to make for every microscope. So, but by now we have installed more than 145 across India, and a few in Korea, Brazil, and also in few in Saudi Arabia. So now I have the measurements of almost all the microscopes, the optical measurements as well as the mechanical measurements. So almost all the known microscopes, well-known microscopes, I have the OmniGlow devices ready. The only thing is that every microscope has its own optical fingerprint, every single microscope. Like Zeiss Visu 150 with Dr. Harshul Tak and Zeiss Visu 150 with Dr. Virendra Agrawal may have a slightly different fingerprint. It's like every rifle has its own fingerprint. So I have to send my optical engineer to install and align perfectly with your particular microscope, even if the model is same and the make is same. So it takes a lot of resources and efforts for us to go and fit the OmniGlow at your place. So the cost depends on microscope's model and how far you are located from Bhavnagar. So, but it's something like 2.5 lakh rupees, plus or minus the cost of travel. And some of the times we have done that, like for example, in Pune, 9 doctors bought OmniGlow at a time. So I had to go only one and stay there for 4 days and attach all nine microscopes. So our travel cost was reduced. So we reduced the price for Pune group. So if there's a 3-4 eye surgeons buying from the same city or from the same region, we can pass on the cost which we save in our travel.
So I would just like to ask you.
I'm sorry. But
I would just like to ask you about the concern of the distance of the working distance between the OmniGlow and your field of surgery. So does that reduce, or does you have to change your style of doing surgery? Keeping your wrist in a more horizontal position, because the working distance reduces if you're adding an attachment to the oculars.
Right. So the working distance decreases by 22 millimeters. So most of the microscopes have a working distance of 200 millimeters. Now this will now become, say, 180 millimeters. Okay. And none of our ophthalmic instrument is longer than 90 millimeters. So even after OmniGlow, there is a 90 millimeter clear space between the bottom of the OmniGlow and the eye. So for the surgeon, there is no problem. For the assistant, he has to be little careful while crossing the field from right to the left when he gives you an instrument in your hand. And we have installed 145 so far, and almost all the surgeons have become used to in 2 or 3 surgeries, even on day 1. And the assistants have to become slightly sensitized that they don't touch the OmniGlow. If we want to increase the focal length, then we have to buy a 225 or 250 mm lens from the microscope's original manufacturer, and that would add about 60 to 70,000 rupees cost. So there are 2 options. Either we spend 70,000 more from buying a 250 mm lens from Zeiss, for example, or we just get used to. And almost, I never had to change OmniGlow or take it back for this concern of slightly reduced working distance.
Okay.
And there is another option is above objective OmniGlow. My current model is below objective OmniGlow. That means it is under the objective. The other model can be the above objective OmniGlow, in which the objective comes at the bottom. But in that, the objective lens gives certain amount of reflection back into the microscope, the surface, the convex surface of the objective lens. And for that, we have to tilt the objective lens in such a way that it induces slightly astigmatic vision. So we tried both the versions, and after trying by about 10 to 12 friends in Gujarat, we came to a conclusion that below objective version is better than above objective version.
So one thing I just wanted to ask, like we have a lot of microscopes that have these astigmatic fan overlay, something like a Virion or something, which can be used to implant toric IOLs. So can something be added to it? Like, I know it's just a thinking aloud. So maybe just adding an astigmatic fan or something to kind of assist optically as we do it for toric IOLs by a lot of microscopic systems they have inbuilt these days.
Oh, that's thank you very much for that suggestion. But that would be another Herculean task, because that will involve a transparent LCD screen to be incorporated somewhere, which will illuminate only when you need, and otherwise remain transparent. So that requires very long research and technology.
No, but sir, you have done a very commendable job. Like this is really out of the world, because the images are absolutely super. So I was just thinking, because you have done it, so maybe you can just add little more kinds. The dil maange more wali baat hai, sir. कितना कर लोगे और एक आगे?
Thank you very much. That seed has been sown, so I'll start growing that seed. Thank you. Thank you.
I thought this seed is already there, Dr. Jagdeep. Yeah, I really thought that must be in pipeline.
He needs more watering. Yeah.
Can I ask you a question?
Please.
Yeah, congratulations, Dr. Jagdeep. Wonderful. I wanted to ask you about a UV glow. So when you put the UV glow on, does it cause, because normally when we are exposed to UVC light, it causes damage to the cornea. So if you are using UV glow, won't it cause keratitis, which would be there with any UVC source?
No. The UV glow are two actually. We are still developing. UV glow is UVA and UVC. So UVA glow is for treating keratoconus. And UVA has already been proven safe for the cornea by Dr. Theo Seiler, and it has been in use since 1998. UVC has a very shallow penetration depth in the cornea. It does not go beyond 300 to 350 microns of cornea. So even it does not damage the corneal endothelium. And we protect the remaining of the conjunctiva as well as the sclera by putting a UV filtering contact lens, which will have a hole punched this, and that punching of the hole will be done by the keratoplasty trephine, and the trephine of various sizes are available from 3 millimeters up to 6-7 millimeters. So what I usually do is I punch the sterilizable contact lens, which is UV filtering, then put it on the cornea and then expose. And the UVC kills the fungus in about 45 seconds, and it kills the bacteria in about 30 seconds. The exposure is only about a minute or minute and a half. And in 1.5 minutes, you destroy all the microorganisms. So, I mean, me and Dr. R.C. Shah, we have been treating corneal ulcers just by UVC without using any antifungal or any antibacterial topical eye drops. And just adding methylene blue eye drops, because methylene blue has a great antifibrotic property, so that the corneal fibrosis and the healing, corneal fibrosis during the healing decreases. So a fairly good transparent cornea is achieved at the end of 2 months.
Yeah, thank you.
Any other comments from the panel?
I think there's a lot of experience with Dr. Kakadia for using UVC, that is a Coronash. So UVC is having different properties than UVA, that is a thing. And I think really impressive. The OmniGlow is a glowing thing, and it is one of the biggest innovation he has done. And may I request Dr. Rajkumar Sharma and Dr. Sandeep Vijay to have his talk on IOLs on ROS platform. It is also a big innovation.
Agreed.
It is a kind of a monofocal lens, no rings, but it gives focus at a near distance, all very clear, and no glare, no halos. So if Dr. Kakade agrees and our ROS executive agrees, I think we can have his talk on the ROS platform in the coming future. And
coming to
wonderful innovation by everyone.
Coming to the innovation, sir, I just want to ask Dr. Virender and Dr. Rahul Sharda, Dr. Harshal, how, of course, when you are a beginner, you use the dye more frequently. And of course, if it's a small pupil, this innovation works greatly. But if you're using a lower end microscope, the basic models of the microscope, and it's a well dilated immature cataract, how much red glow do you actually need? And if you tilt the eye, you get a glow, of course, not that as much as if you're using a OmniGlow. But how frequently you feel hampered by the surgery, by the lack of red glow if you're not using OmniGlow? So can you enlighten us about that?
If I speak, then the moment I started using red glow, my cataract surgery has changed. I started this almost since 2000. The first microscope I purchased was a Mollavidal, and with the red glow, I started seeing cataract also in detail. And before that, I was using non-red glow microscopes, So those were the troubled days. I didn't say that they suddenly changed, but when you start seeing clear, you can actually do the things what you want. And the Rexis, Phaco, and the Red Glow, they all goes one in hand, means to make your surgery safer and you can do actual work what you actually wanted to do. So the Rexis started very well with the Red Glow. That is the one thing. And when Rexis started well, your catheter surgery becomes more predictable, more controlled. So I think Red Glow is required for catheter surgery in all cases. That is my first requirement.
Yes, Dr. Jagdeep.
So it's not only the red glow, but it's also a great enhancement of stereopsis. You know, I cannot demonstrate the stereopsis on a video screen. You have to really perceive it by taking a demo of OmniGlow. And I tell you that if you do 5 surgeries in OmniGlow, and if I take it back, you will not allow me to take it back, because on 6th surgery, you will feel that your own microscope stereopsis was so poor so far, and you got used to it as if a one-eyed person without the stereopsis lives the life happily. But once you have perceived the enhancements of stereopsis with the OmniGlow gives, you will not like to operate without it. That's absolutely sure. Number 2, the contrast increases so much that when you are cleaning the anterior capsule or when you are doing,
I agree with you, sir. 100%. Yes. Yeah. Please continue.
Even cleaning the posterior capsule microfibrils, you can see every single fibril. While doing pediatric cataract, if you are doing posterior capsulorhexis, you are always so confident doing posterior capsulorhexis as if you are doing the anterior capsulorhexis. And if there is a PC rent and the vitreous, if vitreous prolapses into the anterior chamber, you can see vitreous. You can really see the vitreous phase and the phase between the visco and the vitreous. So almost with OmniGlow, you will never need to even use triamcinolone to stain the vitreous if you have to do vitrectomy. So it's not only the glow, but it has many other advantages.
Really amazing, sir.
I agree with you, sir. And this was the difference between Molaviden and Zeiss. The Molaviden IR had a highest depth of the stereoscopy was very good.
Exactly.
And because of that also, I got an advantage. And that is how I started doing polishing of the posterior capsule since 2000 in very well. And now it is my passion to do a posterior capsule polishing to remove each fiber from the capsule. So I agree with you, sir, 100%.
I'll just inform you a little, sorry, Harshal. I'll just let you know a little technical detail. The Zeiss microscopes, all Zeiss microscopes and all Japanese microscopes have a stereo base of 22 millimeters. That means the right channel of the zoom and the left channel of the zoom, the distance between the two zoom channel is 22 millimeters. With Leica, it is 24 millimeters. And with Moller-Weddell, it is 26 millimeters. So as the stereo base between the right and the left zoom channel increases, the stereopsis increases. So OmniGlow increases the 22 millimeters base of the Zeiss microscope optically to 25 millimeters. So it's almost like Moller-Weddell, or it's even little more than the Leica's stereopsis. So that I cannot demonstrate on any video. You have to take a demo of it, and the moment you see it, you perceive that stereopsis enhancement.
So, Dr. Jagdeep, 1 second. That means if you add OmniGlow to a Lumera Eye, it'll become something phenomenal microscope?
Yes, sir. Sir, doc, you will be surprised. Dr. Debashish Bhattacharya from Disha Institute, he purchased Lumera 700, and then he had Visu 150, which was lying, so he wanted to convert Visu 150 into stereocoaxial illumination for his fellows and residents. So I installed OmniGlow in his Visu 150, and then he operated in Visu 150, and he said that I am seeing better than Lumera 700. I want an OmniGlow for my Lumera 700. So I never imagined that somebody having Lumera 700 will need an OmniGlow or will ask an OmniGlow for me. So I had to specially design an OmniGlow for him and Dr. Barjor Banaji from Bombay. So they are now using OmniGlow on Lumira 700. These two cases. And they don't switch on the Zeiss illumination. They operate the entire surgery on OmniGlow on Lumira 700. And their opinion is very clear that OmniGlow gives better stereopsis and better glow than Lumira 700 itself.
Yes, sir.
Right. Good.
So,
Can I make a quick point, Vishal?
sir, a quick last comment by Dr. Harshul, then
Yes.
we'll wind up here.
Yes. So I think Dr. Jagdeep, it's the greatest service you have done to the fellow ophthalmologists, especially to the younger ophthalmologists who can't afford Lumira, Microsoft like Lumira, to get this stereo, course the illumination, which is very essential, as Dr. Virendra also said, at a cost which is just a fraction of the cost of Lumira. Congratulations, Dr. Jagdeep.
Thank you.
Amazing.
Thank you, sir.
Thank you, sir. Thank you. Thank you all the speakers, panelists, and delegates for having logged in for today's program. We are, way out of our time. So we have to conclude. We have many questions, but we cannot take them right now. And it was an excellent session with a lot of learning for all of us. I also thank Bayer for providing the logistics for today's webinar. A very happy new year to all of you, in the hope that we all will be seeing each other in person in the near future, perhaps in the next year, early next year. Thank you all. Any concluding remarks by Dr. Virendra Agarwal?
The only request to Dr. Kakadia sir for providing a special cost to the member of Jaipur Ophthalmic Society for his OmniGlow. So I will try to collect number of people who are actually interested, and if it can be done in 1 or 2 sittings, so I think it will be saving cost for you and for our members also. So that is my request to Dr. Kakadia. And
Whatever
all the
Dr.
innovators
Virendra
are really
Agarwal's
thankful
ajna
for
will
sharing
be
your
instrumental
experience.
for me.
So not only to Jaipur, whole
Thank you,
Rajasthan Ophthalmic Society.
Yeah,
You include.
yeah, I agree. Yeah, I agree, Arshul, with you. And I think it is a request from Rajasthan to Gujarat.
Traveling from Gujarat to Rajasthan is much easier.
And it's the neighboring state, no? Neighboring state.
So that's what I'm saying. The request from Rajasthan to Gujarat, which are neighboring states.
Dr. Jagdeep, you have many friends and they will, turn into a huge loss if you, keep fulfilling everybody's demands.
Not lost. We'll give him the cost, what he is incurring, but his profits will be cut down.
Exactly.
And really thank you everyone and all the delegates who are still with us till end. Thank you very much.
Thank you.
And happy new year to all.
Yeah.
Thank you.
Sir.
Bye-bye.
Good night.
Bye-bye.
Thank you. Thank you. Thank you, Vishal.